I am in the position to present the next speaker. It is a pleasure again to present our next speaker, who is Dr. Oliver Stumper. Welcome, Oliver. Dr. Oliver Stumper was born in Germany, studied medical school in University of Bonn. His cardiology, pediatric cardiology training started there, continued in Thorax Center in Amsterdam as a senior fellow research. He did his PhD there in Amsterdam, and then he decided that he has to cross the channel, and he came in a position in Edinburgh. In 93, he was appointed as a senior registrar in Birmingham, and then he had the position of consultant in Birmingham, and later on in Queen's Elizabeth. Of course, his outstanding work and knowledge in interventional cardiology is mirrored through the numerous publications that he has written and supported. His reputation for his extraordinary skills in cath lab is well acknowledged all over the world, and he is a mentor in 3 continents, I think: Asia, Africa, Europe, and UK. Please, I am passing the panel to you in order to start with your talk, which will be making the most of a hybrid cath lab. And as we have one, we have to know how to use it. Please, Oliver.
Yeah, thanks, Marinos. Thanks for the invitation. Really, first of all, I trained in Rotterdam, not Amsterdam, and that's, if you ever lived in Holland, is quite a difference.
Yes, you are right. Sorry for that. I apologize for that.
But secondly, also, I think it's very important, and I was delighted to listen to Chen's talk. I was attracted from Rotterdam by my teacher and friend, Mike Bodman, who also was very instrumental in the training and development of Chen. An amazing guy, and president of the BCCA in the past and so on. I owe Mike a great deal, and it's good to see you, Chen. Anyway, thanks a lot, guys, for inviting me. I have no conflicts of interest to declare. And really, I would like to express my honest best wishes for your new pediatric cardiac center at Leicester Royal Infirmary. It looks bloody amazing. It's extremely well done in these difficult times. And also on top, you have apparently secured and built a pediatric cardiac hybrid theater. It's amazing. And I wish you every success for the future. Now, Riz asked me to really speak about making most out of it. The hybrid theater, and effectively hybrid, and you all will have seen lots and lots of talks about it, and people showing some strange animals and so on. To some extent, it just describes that surgeons and cardiologists working together in the same operating theater. I think we are married anyway, but quite often, we work in separate spaces. And hybrid describes the fact that we actually start working more closely together. And this was really, let's say, propagated by 2 groups. One is Dietmar Schwanz in Gießen, together with Hakan Akinturk. And the other group was Columbus, Ohio, John Cheatham, and Mark Galantovich. And to some extent, when we go through the details, but both of Dietmar and John Cheatham were very established pediatric cardiologists and interventionalists, and had, say, relatively junior surgeons, or surgeons who certainly could operate and so on, but who were still very, very open to a new approach to it, and possibly also were not desperately keen to do everything on bypass. So Dietmar came up with the idea of bilateral pulmonary artery banding for hypoplastic left heart syndrome, or for that matter, cardiomyopathy in young children, where the right ventricle was still strong enough to support the systemic circulation. He then kept the children on prostaglandin, and then later did a septostomy stent of the atrial septum, or plus minus ductal stenting via the femoral vein, and then progressed to a comprehensive stage 2. This concept, to some extent, then was modified by John Cheetham with Mark Galantowicz, and they basically, in a single procedure, applied bilateral pulmonary artery bands, stented the duct through the main pulmonary artery, and also did a septostomy stent of the atrial septum if needed. And these were basically the hybrid approach to hypoplastic left heart syndrome. Why hypoplastic left heart syndrome? It's actually quite a common lesion in Caucasians. I think there are about 200, 250 children born in the UK alone, but it's also very prevalent in the States and in Europe and so on. So there was a big volume of work which could suddenly be treated in a different way from the Norwood operation, which again at that stage still carried a huge mortality. And really this concept of hybrid intervention then transpired or went into other fields. And the rationale behind it was really to allow improved access, exposure to cardiac interventions, especially in small children, either by providing a carotid cut down, as also used in ECMO, and also paraventricular approach. And the idea was also to reduce or avoid cardiopulmonary bypass, especially in smaller children or preemies. One could do procedures together. The cardiologist could close muscular VSD, whilst the surgeon possibly closed the paramembranous VSD and repaired the pulmonary artery after previous banding. Exit angiography after complex repairs became suddenly a possibility with the introduction of hybrid theaters. And also there were numerous reports on joint working on branch pulmonary arteries. So the surgeon patching out as far as possible as they could get, and then the remainder of the repair being done by a direct implantation of a stent. But these really required vision and teamwork. And also they required certain building adjustments. You needed a cath lab with theater specs with regards to air changes, airflow, but also lights, not the candles we were used to in the cath lab previously. And you needed space, you needed more pendants, gas supply, suction, diathermy, etc., etc. And interestingly, for example, the UK specification of a cath lab, I think still says minimum floor space is something like 36 or 40 meters squared, which for pediatric use is nonsense and certainly not possible for hybrid use. And equally, cardiac theaters, cardiac surgical theaters, suddenly had to be converted or designed with radiation in mind, i.e. the walls had to be lead lined and so on, but also specifications of size again and where to place tubes and so on. Why doesn't this work? Yeah, and then let's say we go through a couple of papers. Ralph Holzer, he worked together with John Cheetham and Mark Galantowicz in Columbus, Ohio. They then published a series of papers, completion angiography after cardiac surgery. And again, Ohio had quite a number of hybrid stage 1s. And they basically reported a series in 2009, 32 patients, mean age 7.5 months, 56% unexpected pathology, and 28% led to a change in therapeutic management. To some extent, yes, these numbers are not uncommon if there's a new technique and try to promote it. But you have to take it with a pinch of salt, I think, especially these days. And they, especially Columbus, Ohio, and together with Mario Carminati in Milan, actually, they came up with a series of conferences, ISHAC, alternating between Columbus and Milan, and really propagated this concept of hybrid working to pediatric cardiologists all over. Heavily promoted, publicized 2005 to 15 annual conferences, numerous publications, and so on. And basically 2 types of cath lab or of hybrid theaters evolved. The hybrid cath suite, which still has biplane angio equipment and a fixed table with carbon fiber top, obviously, and so on. And then the hybrid OR suite, which is basically a surgical theater. And the surgeons, as you can see, they wanted the different table, breakable table. I'll come back to that later. But they're basically the same things, other than in the hybrid OR suite, they're normally just a single plane system. And in Birmingham, yes, we basically also rode the wave of embarking on hybrid procedures. And I again come back to that. Birmingham certainly at the time was a very surgically dominated department with Bill Braun there and so on. Bill, I think in his later years, and Joe will probably echo that, mellowed very much towards interventional cardiology, but certainly in the early 2000s he was very, very surgically minded. And so it was a bit of an uphill struggle to introduce some of the newer interventions. In 2011, finally, we were lucky enough to have a new biplane cath lab. In part, that was because also the old equipment was 13 years old and so on. And at the same time, we built a hybrid cardiac surgical theater. And the beauty of the installation in Birmingham to this very day is that it's really one complex, and there's a shared prep areas and stores, central control room, and you're right next to the surgeon. And yes, we're trying to train staff in both scrubbing for cath and scrubbing for certainly simple surgical procedures. And let's say with this rapid take-up of hybrid concept by pediatric cardiologists, cardiac surgeons, I think the industry again was pushed into developing hugely. So a company who could no longer, or who didn't have a hybrid system in their catalog, suddenly was facing problems or less demand. And in all fairness, they did great things, great development also in table. This is a traditional surgical table which is breakable, but now you can replace sections of the table with carbon fiber tops and so on. And it has become a must for X-ray companies to have a hybrid system in their catalog, as it is a must nowadays to have an electric car. And yeah, then when you look at it, another paper from the US, again, Ralph Holzer, 2010, congenital heart disease, how much real uptake or clinical activity there was despite all the hype. There were 7 institutions, nearly 2-year period, 7,000 cardiac caths, 128 hybrid procedures. That's only 1.8%. And between these 7 institutions, number per center was 1 to about 90. When you do the math, that's a median, about 8 hybrid procedures per center per year. And this may have increased slightly in North America from then on. But a lot of these were diagnostic, i.e. exit angiography, stenting the ductus. Most of them will have been stage 1 Norwood a la Columbus, and probably the majority of them actually have been done in Columbus. VSD device closure, and they are mostly muscular VSDs, there were only 7 over 2-year period in 7 institutions. And vascular rehab, which is normally working on pulmonary arteries, 25. So the actual clinical activity in these hybrid theaters up to 2008 was small. From 2005 onwards, there were numerous reports and papers on paraventricular muscular VSD closure, some very beautiful pictures and publications and so on. But these defects are actually kind of rare. And most of you will have done them yourself. Sometimes it's actually difficult to cross the VSD if the defect isn't humongous. Bristol, for example, 2005 to 2013. So let's call that 8-year period. 10 paraventricular device closure of muscular VSDs. This is about 1.5 a year. Epicardial transesophageal echo, and really there's very, very limited patient numbers when you come to it. Hybrid interventions, again, Chinese experience. Chinese have huge number of a population and congenital heart disease which hasn't been operated, and equally, let's say, fairly soft indications, I dare say, to some of the VSD closures. They are reporting huge numbers, 60 per paramembranous VSD closures, yeah, per ventricular, so basically limited sternotomy, stick a sheath in and close the defect under echo guidance. This is per ventricular in relatively small children. And now this technique has progressed. Pan basically reported on, I think, 800 ASD and VSD closures under echo only, not even a C-arm in the room. So there is competition out there to do these. Now, coming back to the hybrid, and as I said, the mortality for surgical Norwood stage 1 has decreased dramatically. And as you all know, there has been a comparative study, Congenital Heart Surgeons Society, looking at outcome of basically classical Norwood versus Sano type Norwood versus hybrid Norwood. And certainly Sano Norwood is followed by improved survival, and at certainly 1 and even at 4 years, whereas the hybrid remains roughly the same as the classical Norwood. And then when they looked at ages, basically the hybrid certainly conferred an advantage against the classical Norwood in children, let's say, below 2.5 kilogram in body weight. And this was basically one of the indications. So a kid who was young, who was small, who had comorbidities or NEC or something like that, they were considered for hybrid in most centers other than Gießen and Columbus. But let's say Gießen and Columbus data have not been replicated really in any of the other centers. And I think Guy's or Evelina basically went into the hybrid at some stage, but to the best of my knowledge, they again moved somewhat away from it. And in Birmingham, we were allowed to do hybrids basically when the kid was really more or less dying. pH of 6.7, 6.8 or something like that, and really, really struggling. And we tried hybrids. These kids were desperately sick, and our survival for a strict hybrid approach, even with Gießen modification, i.e. bilateral band, and then keeping them on prostin and then stent duct at a later stage, they were not good. And now what we're doing in sick hypoclass is basically band their pulmonary arteries, rest them for a couple of weeks, and then convert them to a Sano type Norwood at a later stage. Now this is again one paper which to me is casting doubt as to whether the hybrid approach for Norwood is really the best thing. Again, Ralph Holzer looking at pulmonary arteries after hybrid stage 1, and you see that the pulmonary arteries are probably never going to be good enough to have a fontan. I won't go in there. And so after 10 years journey of hybrid, certainly also at Birmingham Children's Hospital, and we had, or I personally certainly had great expectations and had hoped that there would be a great surgical buy-in. And probably in retrospect, I have to term that as a peak of inflated expectations. certainly I hope I'm through the trough of disillusionment, and I hope we can in future establish some sort of agreement what we're going to do hybrid and what not. But it's not an easy journey. This is the UK data for all 13 or 12 centers in the UK, and you see that the number of hybrids throughout the UK remains fairly small. Let's call it 80 a year, and compared to surgical or interventional volume, this is tiny numbers. Hybrid intervention in congenital heart disease needs a team approach, needs good communication, and you have to learn to work together, and you have to trust the surgeon, the cardiologist, and vice versa. It's a process. And what gets me quite often in Birmingham is that we are asked to do, oh, come to the hybrid and do an exit angio. The patient is not looking good. For example, after arterial switch or PA recruitment, pulmonary atresia, and so on. To do exit angiography when things are not good is helpful, but is not building an effective team or program. And you have to scrounge around to find a radiographer, scrub nurse, and so on. You have to try and work together in peacetime or when things are good to establish protocols and procedures. Hybrid intervention in congenital heart disease, it takes huge capital investment, which luckily you guys were getting. It needs a fresh mindset. But also it probably needs moving away from counting minimum bypass procedures or minimum cath interventions. Because, yeah, if surgeons have to do 100 bypass, cardiac interventionists have to do a minimum of 100 interventions, what is the stimulus to say, oh, I don't have to do a bypass, I can do it together with you, and who is counting the procedure? But it also needs revising of training programs. I think people are well advised to get some basic training in cardiac surgical techniques, having said that cardiac surgeons should also learn how to do echo and how to do hemodynamics, for example. And when you compare training in pediatric cardiology, stroke cardiac surgery, it's still, let's say, very watershed territory. Whereas in vascular surgery, I think there's much more embracement to work in a hybrid style. And a lot of vascular surgeons now working hybrid on a routine basis. I think there's lots to be said for hybrid approach. And this is a patient or a picture of Mark Givilic doing an RVOT stent in I think 2.1 kilogrammer. To some extent, why shall I struggle to try and do it from the vein or perforating an atretic pulmonary valve in pulmonary atresia intact septum, if basically I can ask the surgeon to open the sternum and we can get direct access to the right ventricle. Carotid artery access, again, I think is a very good thing, even though now cardiologists are increasingly using percutaneous carotid artery approach. I remain somewhat hesitant about that because we certainly can't repair the artery, and we should work together more closely. Pulmonary valve implantation, there are so many different designs nowadays. I personally think either we work together soon, i.e. in a hybrid with limited sternotomy and so on, and like Massimo Caputo in Bristol, he's using injectable pulmonary valves, but we can also use a short sheath and put in any valve more or less through the right ventricle, reduce the size of the dilated outflow tract and do it non-bypass. And eventually I think we will do pulmonary valve replacement in follow with transannular patch and severe pulmonary regurgitation in all kids who are 30 or 40 kilograms before their RV reaches 140 mils per meter squared. I think that's the way to go. And if we don't work together, then let's say the device companies and catheter companies will soon come with a 14 French system and we do it anyway percutaneous. Same, and Vinay would be the best to talk about this. I think there's a lot to be gained from a hybrid approach for electrical work, biventricular pacing, hybrid systems, ICD work in smaller children, huge potential. And this picture actually is a melody valve implantation in Leicester, and the subsequent balloon dilatation from the LV apex. Marinos gave that to me. I think there's so many devices and so many techniques out there that really working together in small children from a hybrid approach, I think, is the way forward. But we have to be able to A, work together, and B, have a vision, and also stop counting our minimum numbers. So far, I have to say, uptake actual numbers are poor. There has been a limited catheter company support for development because there are only 80 procedures. But we are still messing around with catheters which are 80 centimeter long, wires 150, or the coronary wires 180 centimeter. We don't need that if we work hybrid. As I said, minimum number of procedures and counting of everything doesn't help. And as I also said, we need to modify training and exposure. And yes, it's a way forward to embrace the future. And again, very delighted to hear that you're going big steps that way. All the best. Thank you.
Thank you very much, Oliver. I really apologize for the mistake I make. And
I'm not Dutch, don't worry.
And I really find your talk very fascinating in the way of exposing the real life there, because most of the time we do not hear what you have already showed us. And what I wanted just to ask to you, in the way that it is pediatric cardiology more in the Western world, I would say, or what we call developed worlds, United States, Canada, Australia, Japan, China, Europe, that we do not have so many nowadays intervention catheters in order to train the new people, the new colleagues that they are coming. Is hybrid a safe place where the new guys could have the help of the surgeons and start doing interventions, and so gaining experience there? Because it's different to go and try to do an intervention, even if it is the simplest intervention from percutaneously, than to go and do, for instance, a balloon valvuloplasty under direct vision, or with a Perseus string in the outflow track, and say, yes, this is what we are doing now, and that's okay. What do you think about that?
Well, yeah, no, I mean, the numbers are decreasing, and equally, yeah, equally the goalposts have changed. Yeah, nowadays, yeah, you have to have a high success rate, low complication rate, and so on. It's difficult for younger people. I think they have to go to high volume centers, and as you quite rightly say, some places in Europe and the United Kingdom don't have those high volumes. My trainees, I certainly would encourage them to spend some time abroad in Asia and other places. I think in order to work together in a hybrid theater or hybrid fashion, you have to have equal partners, and to send the junior interventional trainee in balloon and pulmonary valve with the surgeon doing the bypass, I don't think that's going to work. A very patient surgeon. No?
Yes, I understand. I take your point. I mean that for us it is safe for the guys, and I place also myself there, where we have not been exposed in the cases of 1,000 cases before we start saying that yes, we are doing all kinds of interventions. because they were not the cases there. Sometimes the hybrid procedures, I saw that in Germany, in Bad Oeynhausen, it was a very safe way in order to do things and to place stents in pulmonaries, to do standing in Norwood before the Glen or before the Fontaine completion when we had problems there, or to go even for closing of VSDs. This was an easy and more safe and secure way to do things. And with expected good results, because the results have to be good, and with also less complications for the patients. This was the most important thing I have seen in the hybrid theater. Rees, I think you have a question to.
Yeah, hi Oliver, thank you. That's an amazing talk. I think that gave us a lot to reflect on and a lot to think about moving forward. There's a lot of people in the audience who are from all over the world, different centers. How important, or do you think people planning new buildings, new cath labs, how important is having a hybrid? Do you think it is a luxury or not?
Me?
Yeah.
No, well, first of all, it's a luxury. I think it's the right way to go, as I said. Having said that, we have a hybrid in Birmingham, and from 2011, yeah, so it's 10 years old now. We may have to consider replacing it. Now, if I were a finance manager in the NHS, yeah, I would say, okay, how many times have you used it? Yeah, how much does it cost? And do you really need it? Yeah, and to some extent, yeah. For example, all the perventricular VSD closures, yeah, you can do with an echo. You don't need a CR, yeah. Exit angio, yes, you need some sort of CR, but you could also even take a mobile CR. You don't need a hugely expensive system. I think where it will come really is, for example, pulmonary valve replacement. Yeah, I mean, they should, I think, all be done hybrid. Yeah, or let's say if the patient is big enough, okay, you can do it transvenous or percutaneous, but why not do it hybrid and reduce the outflow tract at the same time? I think, and Joe alluded to it, yeah, there are so many new techniques of transcatheter valve repairs. Yeah, again, a lot of them probably done better with a hybrid approach. Yeah, so I think it's an evolving field. I think it's luxury. I think, yes, in order to move forward and push it forward, you have to invest huge, yeah, to make small gains. Yeah. But at present, I personally would struggle to write a business case to have it to replace.
Yeah. Thank you, Oliver. I think Dr. Chan has a comment to make. Dr. Chan, do you want to?
Yeah. Oliver, excellent talk. And I think you hit on the note that is extremely important, that we should not use the hybrid as a bailout for the surgeon. It should be pre-planned ahead. Now, most of us have been called to the OR and the surgeon says exactly what you described. I need a hybrid. If you look at the drapes, the number of lines all over the place, and then trying to shoehorn in the C-arm, it's a total pain. And you can hear the number of swear words that were exchanged between the parties. So if we have a hybrid that we think may be used, we would have placed everything ready. Then not only that, you got to get everybody, get out of the room. We are going to shoot some deadly death rays and then come back in again. You know, so I think your comment is extremely vital. Plan ahead. Don't do it as a bailout. And I think if you do that, I think it will work. One other two comments on the indication that we have now discovered that in our hypoplastic left heart with intact atrial septum or the extremely restrictive atrial septum that were prenatally navigated, we actually deliver the baby just beside our OR cath lab, bring it across the surgeon, make a small incision, and we go directly through into the atrial septum and then open up the atrial septum. Even if it's a small hole, it's enough to keep the baby alive, then we can take them to the cath lab 2 days later or something to open it up. Trying to do atrial puncture and septostomy in a really sick kid with those situations is going to be tough. The other thing that we have used is in transpulmonary valve placement. We are now using circumference rather than diameter. We pre-calculate how much reduction in the circumference that needs to be done. And if we can't put a valve in the cath lab, the surgeons will open the chest, reduce the circumference as how we calculate to them, then we would know the diameter and we then would place the valve in. So those are the comments I have. Excellent talk again, Oliver, and good to see you.
Thanks.